Anterior odontoid screw fixation is a procedure that uses an anterior cervical spinal exposure to insert one or two screws into a fractured odontoid process. The goal is to stabilize and fuse the odontoid process while preserving atlantoaxial range. The procedure is indicated for acute type 2 odontoid fractures, particularly transverse fractures. In this video, we will discuss the steps of odontoid screw fixation in the context of the case. In this case, a 47-year-old man sustained a motor vehicle accident. These images are from the patient's preoperative CT. These sagittal and coronal views demonstrate a type 2 odontoid fracture. Before we can talk about the steps of odontoid screw fixation, we first need to talk about the setup of the case. The first step is to position the patient supine with a folded sheet or similar support under the shoulders with the head extended. Importantly, you should use two image intensifiers to identify the odontoid process in the AP and lateral views. Place a radiolucent bite block to keep the jaw open in order to have a clear AP odontoid shot. Your next step is to reduce the fracture prior to surgical access. There are a number of strategies for this. You may need to flex or extend the head preoperatively while the patient is on the table. You should also know that you may need to reduce the fracture intraoperatively as well. Make use of frequent visualization with CM fluoroscopy while you do this. Now, as you may have deduced, these lateral and AP images were taken while the patient was on the operating table. The lateral view demonstrates reduction of the fracture. The AP view shows good visualization of the odontoid. Once you've reduced the fracture, you should plan your incision by estimating the intended direction of the screw. Do this by using a K-wire or a similar radio-opaque object, holding it alongside the neck and viewing its position on fluoroscopy. The incision should be where the K-wire will exit the skin. In most cases, this is at the C4-5 level. Make your 2 cm incision at the medial edge of the sternocleidomastoid. Once you're satisfied with patient positioning and fracture reduction and the incision is planned, prep and drape the patient. Inject local epinephrine for hemostasis, make a 2 cm transverse incision, and follow that with exposure and retraction. Use a standard anterior cervical spinal approach to expose the prevertebral fascia of C2 and C3. Maintain adequate exposure using the Apfelbaum or similar retraction systems. Take another fluoroscopic image prior to dissection of the prevertebral fascia to ensure accurate localization. Now that the patient is prepped and exposure is accomplished, we will talk about screw insertion. You should plan the screw entry point at the anterior inferior lip of the C2 body, or in other words, plan to drill into the inferior C2 end plate. Place the drill guide instrument on the exposed inferior C2 end plate. For reference, your screw should eventually be angled slightly posteriorly in order to exit at the posterior half of the odontoid tip. With this in mind, drill a trajectory through the tip of the odontoid. As you can see, these images are intraoperative fluoroscopic shots. The top panel shows docking of the drill guide. Note the spike, which helps to fix the guide in place in the C2-C3 disc space. The middle panel shows the drill advancing into the odontoid. The bottom panel shows the drill advanced further, past the fracture line. Now that we've discussed drilling a trajectory, let's talk more about the insertion of the K-wire and the screw next. Once you've drilled a trajectory, insert a 20 cm long 1.2 mm K-wire into the corridor and advance it through the tip of the odontoid. Confirm your positioning with frequent fluoroscopic visualization. Advance the K-wire through the tip of the dens. While drilling, you may need to optimize the alignment of the C2-3 complex and odontoid. Alternating AP and lateral fluoroscopic shots are necessary to ensure proper trajectory. Next, measure the length of the K-wire in the bone. This measurement indicates the length of the screw required, typically 38 to 42 millimeters. Before inserting the screw, perforate the cortex with a specialized cannulated countersink. These images that you see are once again intraoperative fluoroscopic shots. The top panel shows K-wire insertion into the drill trajectory through the tip of the odontoid. The bottom panel shows a cannulated tap as it starts to advance along the K-wire. Once the trajectory is tapped, the screw can then be inserted. Once you have tapped the trajectory, the next step is to insert a self-drilling, odontoid-type, partially threaded cannulated lag screw. You should insert the screw directly over the K-wire. Observe your placement on live lateral fluoroscopy to ensure that the K-wire does not advance superiorly, as this could injure the spinal cord or brainstem. Tighten the screw until the head is countersunk with respect to the C2 body, and 1 or 2 threads of the screw penetrate through the tip of the dens. The top panel here shows the cannulated screw as it advances past the fracture line. The middle panel shows the lag screw at its final position. The bottom panel shows the screw in position after removal of the drill guide. Once the screw is fully inserted, remove the K-wire. Ideally, use the same technique to insert a second screw. The surgeon or assistant may flex and extend the head under fluoroscopic visualization to confirm that there is no C1-C2 instability. Complete irrigation and ensure hemostasis. Then, you can complete the closure. Closure should be done in layers. You may use interrupted absorbable sutures in the platysma muscle and subcutaneous layer with adhesive strips on the skin. Finally, these postoperative sagittal and coronal CT images demonstrate successful odontoid screw placement. And that concludes our video on odontoid screw fixation. Thank you for watching.